Thank you very much for the introduction. It's a privilege for me to be given the chance to present treatment algorithm and metastatic colorectal cancer, especially focusing on Japanese guideline. My disclosure. This is the content in my talk. First of all, I would like to talk about the current Japanese guideline for metastatic colorectal cancer. The history of Japanese guideline for the treatment of colorectal cancer was initiated 2005, updated 2009, 2010, 2014, which is the current version. The English version also published in 2012 for the 2010 version, 2015 for the 2014 current version. Today, I would like to talk about the current 2014 version as well as the 2016 new draft version. The basic principle of the Japanese guideline 2014 for metastatic colorectal cancer, including only approvable injured in Japan. The patient divided into two groups, a patient appropriate for intensive therapy or patient not appropriate for intensive therapy. Determinants of the patient not appropriate for intensive therapy included patient factors and the tumor-related characteristics and so on. Patient factors to be considered are patient preference and the patient unable to administer oxaliplatin, irinotecan, or target agent that is severe complication. The tumor-related characteristics to be considered including multiple metastasis, unlikely to complete resection in the future, asymptomatic slow progression. I want to say the combination with target therapy is strongly recommended, but for patients who are not candidate, chemotherapy alone is recommended. Looking at the patient not appropriate for intensive therapy, in the first-line setting, guideline recommended infusion of 5-FU leucovorin plus bevacizumab or capecitabine plus bevacizumab and oral UFT plus leucovorin in this patient population. Looking at the patient appropriate for intensive therapy, basically Japanese guideline based on all evidence from the Western European and of course the Asian clinical trial. So you can see if the patient not willing to conduct the aggressive treatment, infusion of 5-FU leucovorin, capecitabine plus bevacizumab, and the UFT leucovorin is a recommended regimen in the first-line setting. Regorafenib is a mainstay in the third line and thereafter. The difference between the Western guideline is the IRIS regimen, that is, irinotecan plus S1 combination stated in this patient population. IRIS regimen in the second-line setting was verified in the non-inferiority manner, comparing HOPE versus IRIS regimen in patients with metastatic colorectal cancer who had progressed 5-FU containing regimen in the first-line setting. So now, Japanese situation, most of the physicians prefer oxaliplatin 5-FU combination as backbone and chemo in combination with bevacizumab. In second-line setting, irinotecan plus either bevacizumab or anti-EGFR antibody is a mainstay or last white type. In the looking at the third line and thereafter, regorafenib or TAS-102 is a mainstay in this population. So moving forward to the newly published phase 3 trial in Japan. SOX plus bevacizumab regimen, that is S1 oxaliplatin, bevacizumab combination, in the first-line setting was verified in a non-inferiority manner, comparing the FOLFOX bevacizumab versus SOX plus bevacizumab in the first-line setting. And more recently, FOLFIRI plus bevacizumab was verified in a non-inferiority manner, comparing FOLFOX plus bevacizumab versus FOLFIRI plus bevacizumab in patients with metastatic colorectal cancer, published in Annals of Oncology. So the comparing the Western trial, including the FIRE 3 CRC trial, in the right side, you can see median overall survival around 30 months, consistent result between both populations. So regarding the recent Japanese contribution to international phase 3 trial, you can see LACE trial, pivotal phase 3 trial, ramucirumab phase 3 trial in the second line setting. Sorry, the slide is slightly different. Whole free plus placebo is correct. Sorry. 136 came from Japan in this trial. And in addition, in the correct regorafenib phase 3 trial, 100 patients came from Japan. The LICO STAS1 trial, 266 patients came from Japan. So now the ramucirumab regorafenib TAS1 was approved based on the international phase 3 trial in US, in Europe, as well as in Japan. So now they're moving forward a new Japanese guideline draft 2006. This guideline was yesterday disclosed at JSCCR annual meeting in Japan. So this disclosure is the first opportunity to disclose the international meeting. This is based on the several new evidence, SOX plus bevacizumab, whole field from ramucirumab, TAS102 is stated in this new guideline draft. And in the first line setting, hofoxilib plus bevacizumab also stated based on the result of the THRIVE GONO group, the Italian trial. And the patients are not willing to aggressive treatment. UFT loicobolin bevacizumab and S1 plus bevacizumab also stated in this new guideline draft based on the Japanese phase 2 data. So for looking at the patient, not appropriate for intensive therapy, UFT loicobolin plus bevacizumab, S1 plus bevacizumab also stated in this patient population. I want to say, use of the anti-EGFR antibody is restricted to RAS wild type only in this, of course, in this guideline. So now they're moving forward to the current JASMO, Japanese Society of Medical Oncology guideline for RAS testing. Left-sided, the last kit, in vitro diagnostic kit, was approved last year in Japan. This kit is distributed in Japan. Right-sided, Japanese Society of Medical Oncology clinical guideline regarding RAS mutational testing in colorectal cancer was published last year. So looking at the incidence, minor KRAS and NRAS exon 234 mutation was 60% out of KRAS wild-type mutation. And you can see here that ranging from the 14 to 31% in Western countries. So the consistent result was observed. In addition, mutation in each codon were comparable between the two populations, between both populations. So regarding the relevant issue for Asian patients living in Western countries, as you know, the UGT1A1 STAR28 is associated with a severe neutrophil count decrease and sometimes severe diarrhea. You can see the incidence in Asian population, homotype, 2 to 3%. In contrast, Western series ranging from 11 to 90%. More importantly, especially for Asian patients, UGT1A1 STAR6 polymorphism is very important. You can see here the 4% of the home population. In addition, double hetero, the STAR28 and the STAR6 heterotype showing the lower AUC of the SN38G per SN38 similar way to the STAR28 homo. So the classification of the UGT1 polymorphism subtypes in Asian country, you can see double hetero STAR28, STAR26 was classified homotype. So moving forward to the circumstance in other Asian countries, a consensus meeting previously held in Hong Kong in 2012 from 10 Asian countries, unfortunately outside Japan, and the 2 European Union. Objective to develop Asian-specific guideline for the management of colorectal cancer. However, in this conclusion of this manuscript, are few major differences between the Western and the Asian country. No particular new findings stated. So I guess that disappointing result. So looking at the present circumstance in South Korea, regarding the indication of the reimbursement, indication does not mean reimbursement. Bevacizumab is reimbursed first, second-line setting in combination with FOLFOX or FOLFIRI. Cetuximab is reimbursed in first-line setting in the combination with FOLFIRI. The use of second and third-line setting of cetuximab is indicated but not reimbursed yet. LEGO is indicated but not reimbursed. Regarding the role of RAS in the field of metastatic colorectal cancer, you can see use of the EGFR inhibitor should be confined to RAS wild-type patient. Direct single sequence is approval for the extended RAS testing. I want to say, most important issue in Korea, cost and reimbursement issue are more important determinants. So looking at the Taiwan circumstance, regarding indication reimbursement, basically similar to the Korea. In the first-line setting, for patient RAS wild-type, FOLFIRI plus bevacizumab, FOLFIRI plus cetuximab, and FOLFOX plus panitumumab are reimbursed by National Health Insurance. For RAS mutant, in the first-line setting, FOLFIRI plus bevacizumab is the only reimbursed regimen. Second-line bevacizumab, cetuximab, or panitumumab are not reimbursed yet. Cetuximab and panitumumab are reimbursed in the third-line setting and thereafter, when not used in the first and the second-line setting. Regorafenib is reimbursed in the third line and thereafter. And regarding the role of RAS testing, use of the EGFR inhibitors should be confined to RAS wild-type patient. Direct single sequence, unfortunately, not approval for extended RAS testing. Similarly to Korean situation, cost and reimbursement issue are more important determinants. So I would like to moving forward to the future prospect. As you know, that Eric and Axel already mentioned that BRAF testing and MSI testing is important to date. So the prevalence of the BRAF mutated colorectal cancer, you can see the incidence of BRAF mutation in Japanese patients around 5%, appears slightly smaller population comparing to the Western population, ranging 8 to 12%. However, survival outcome in patient BRAF mutated colorectal cancer similarly was in both populations. In addition, clinical pathological feature and treatment outcome for BRAF mutated colorectal cancer were consistent between both populations. Looking at the prevalence and microsatellite instability high population, you can see the incidence of the Japanese population only 1.9%, comparing the 3 to 5% in Western population. However, overlapping BRAF B600E mutation is around from the 30 to 40% consistent result in both populations. So just more initiative, new guideline regarding biomarker and emerging technology in metastatic colorectal cancer will be available soon, including RAS testing update, BRAF testing, microsatellite instability testing, as well as the emerging technology, cancer genome alteration testing by NGS, and blood-based molecular testing. So in my conclusion, Asian guideline for the treatment of colorectal cancer does not exist since 2013. International phase 3 trial, including Asia, may play an important role. Clinical development new agent should be incorporated into Asian guideline. Asian phase 3 trial should be incorporated into Asian guideline. I want to say both evidence-based, approval, reimbursed-based approach are key to develop new Asian guideline. Asian guideline is for patients in Asia as well as Asian patients living in Western country. International harmonization, this guideline may become the best way in the near future. Finally, JASMO annual meeting approaching late July, held in Kobe. Kobe is very famous for Kobe beef. I want to say finally, our mission is to provide engaging smile to patient health in the world. Thank you for your kind attention.